Good afternoon, everyone. How's everybody? Good? Thank you all for coming this afternoon. I think you're in for a real treat. There are some of you who may have been in this very same auditorium a couple years ago to hear Bob, and we are grateful that he has agreed to come back down from Northern Virginia on the train and with Uber because driving it is icky. So we're grateful that he was willing to do this. Now, you might be wondering why this is up. Well, Bob and I were just recounting all of our kindergarten friends, and we're both in there. And we were trying to remember lots of other names, so we were taking a quick little stroll down memory lane. But that is indeed how far Bob Graboyes and I go back, maybe even farther.
She lived right behind me.
Right. We lived very close to one another, and it was a great childhood. So it is a real treat for me to have a longtime friend come and join us here at the Osher Institute. And Bob has great information to share with us, and I'm going to just read a little bit of his bio so you'll know. Dr. Robert F. Graboyes is a senior research fellow at the Mercatus Center at George Mason University up in Arlington. Author of Fortress and Frontier in American Healthcare, his work asks, how can we make healthcare as innovative in the next 25 years as information technology was in the past 25? In 2014, Dr. Graboyes received the Reason Foundation's Bastiat, is that it? Mm-hmm. Prize for Journalism, an international competition which honors the writing that best demonstrates the importance of individual liberty and free markets with originality, wit, and eloquence. Previously, he was Senior Care Advisor for the National Federation of Independent Business, Sub-Saharan Africa Economics for Chase Manhattan Bank, and Regional Economist Director of Education at the Federal Reserve here in Richmond. He traveled extensively in Africa for Chase. Twice he was the visiting healthcare scholar in the Republic of Kazakhstan. He has taught at VCU since 1999, UVA since 2005. Previously, he taught part-time at George Mason and the George Washington University, and full-time right here at the University of Richmond, so he's coming back to some old stomping grounds. He earned his PhD in economics from Columbia, master's degrees from Columbia, VCU, and the College of William and Mary, and a bachelor's from UVA. So he comes with a wealth of knowledge, and I'm excited to hear what he has to say about technology and healthcare in the future. So Bob, thank you.
Thank you. And I'll mention my friend Tim here is from Chicago. This is the closest Southside Virginia has to the mafia. Let me see. Peggy, do I just, is it already ready to click on? Let's see.
Just have to put it on the...
Yeah.
Get rid of that. And then it's down at the bottom.
I'll let you bring it up.
And there we have it.
Cool.
Thank you.
All right. Can you hear me? Terrific. Let me know if I ever get too soft, but it's unlikely. So I'm so delighted to be back. Let me ask, Peggy mentioned that I spoke here for Osher in September 2015. Were there any people here? I know there were a couple. How many were here? Great. Well, we won't have too much crossover, but we'll say this is somewhat of a continuation of what I spoke about then. So as Peggy mentioned, I work for the Mercatus Center at George Mason University. It's a university-based research institution If you go to mercatus.org, we have lots and lots and lots. It's a big organization. We've got, I'm guessing, at this point, probably 160 people in our office, and we have literally hundreds of scholars across the United States with whom we solicit research and put out on a variety of subjects. On health, I'm the healthcare scholar. We have taxation, budget, technology, finance, you name it, lots, regulation. So if you end up interested at the end of this, just go to mercatus.org and you'll see lots of stuff from my colleagues. It is a great place to work, as was this place, by the way, where I spent 6 very happy years. So I've entitled this, An iPad Saved Mom, an iPhone May Save Me, Healthcare in the Age of Silicon. So, as I said, my work mostly focuses these days in healthcare on the technological end of it. The nice thing about that is it allows me to be, I like to claim, the only healthcare economist in Washington who can have a pleasant lunch with Democrats or Republicans, because I'm not focusing myself on the Affordable Care Act or the Republicans' alternatives or all the things that get people sharpening their teeth in Washington at one another. This stuff, it's kind of nice because a lot of it's, what you will hear today is, to me, shockingly not well known, even to people in the medical community, people in the insurance industry. So I hope you'll enjoy being kind of insiders after you hear this. And the title, as odd as it is literally true. So, technology doesn't always work. Let's try this. This is my mother at age 18. Same high school that Peggy and I went to. Class of 1940. The last time I spoke here in 2015, Mom was sitting right over there, sitting with my cousins who are here today. And I was very, very grateful to Peggy for inviting me to give that talk because it was the only time my mother ever actually attended one of my lectures. She attended, it wasn't because she didn't want to, but it just, I tended to give them in places where she wasn't going to be. She happened to come here right after a hospitalization, and it was very lucky. I mean, it was just a few days earlier, she could not have come, and that's kind of part of what I'm talking about today. So, what will we be talking about today? So that's Mom. That's the year she was born, 1922. That's a calendar from the year. And yeah, that's actually Mom on the horse. Or at least someone she went to kindergarten with. We're going to talk about calendars. Calendars are very important in what I'm talking about in many different ways. The passage of time, literally the calendar that your doctor has in his or her office. We're going to talk a bit about money. That's a dollar coin stamped out the year she was born. And we're going to talk mostly about technology and the way medicine is changing in a way that, and I do teach over at the Medical Center at VCU, and I will talk to groups of doctors who are either totally unaware or only marginally aware of the things that I'm going to be talking about. Things that I think ought to be universally known, not just by doctors, but by folks in this audience. And it's kind of unfortunate that they may not know those things. On the other hand, it means we've got a lot of low-hanging fruit for improving healthcare in the United States without doing all the political things that you're used to hearing on TV and squabbling, things that just about everyone can be happy with. So we're going to talk about technology. Now this was not 1922, but I think this drawing dates from 1924, 24, 25. And what this shows is a doctor in the future speaking to a distant patient through telemedicine, seeing the electrocardiogram and reading the patient's respiration and taking an x-ray and temperature and blood pressure and listening to the tones of the heart and doing other things, all with a nice candlestick telephone and an old-timey microphone. And also hooked up to a nice car battery. I kind of like that part too. Also the fact that she's wearing a mid-1920s swimsuit. It's just kind of interesting, whatever. Anyway, all of that stuff is now real. I've used some of that stuff. I deal all the time with people who deal with far more sophisticated telemedicine than that. It took a while to come along. And in my view, it's not nearly used enough. And today we're going to see some examples of how it's used and where it's used and the miracles that it can bring about. This is Josh Billings. Anyone have the faintest idea who Josh Billings is? Well, he was, some people call him America's first humorist. He was of Mark Twain's era, maybe even slightly before. And he was one of these guys who, like Mark Twain, or many years later, Will Rogers, that sort, who wrote kind of words of wisdom that became catchphrases around the United States. And one of them he did, and this is written in the style that he did it, was, "Wisdom don't consist in knowing more that is new, but in knowing less that is false." Something that holds true today. I spend about half my time writing in healthcare, trying to dissuade people of truths that ain't so, and that everyone thinks, people on the left and the right, all agree is so, even when it ain't. So here is a fascinating diagram. I contacted the guy who created it. I met him as I meet lots of the most interesting people that I deal with in my career through email or through, in his case, through Twitter. I'm active on Twitter. Does everyone know what Twitter is? Okay. And what this is, and it's very hard to read. I told him he needs to change the font in it. But it's the determinants of health. It's some very sophisticated measurement of what determines your health. I don't know, what's the most important thing in determining your health? What? Genetics is part of it. Zip code is very important for many reasons. So the debate in Washington sort of implicitly or explicitly assumes that healthcare is the biggest reason that determines who in this room is sick and who in this room is healthy. Well, ain't so. Not by a long shot. Some of you may have heard the World Health Organization produced one of the single worst pieces of research I've ever known of about 17, 18 years ago that showed the United States performing very poorly against other countries. The phrase from it is that the US is only number 37 between Slovenia and Cuba, and we spend way more. Well, very little in it, it's true. Its own editors have rejected it, renounced it, saying this was a bad piece of work, and even the extent that some of it was accurate, it's been badly misused. The United States, in the scheme of things, has a fantastic healthcare system, and we outperform most countries in most ways. Are there problems? Yes. They're not typically the problems that that particular study showed. But the implicit in the assumption of that study is that healthcare explains the whole thing. Therefore, when people say the United States is number 37, therefore our healthcare system is bad. Fourth rate, as I just saw, someone tried to show me a video on the subject. And I said, once you get to that statement, 1 minute into this hour-long thing, it's over for me. If anyone believes what the journalist who was doing it said. So one of the really common statistics you'll hear is, oh, the United States, we pay all this for healthcare, and yet other countries have longevity up here, and we're way down here. We're near the bottom of the developed world. It's not entirely false. But the story is this. If you look at all the people who die overseas in England, in France, in Japan, in Germany, in all of these countries, and then you look at all the people who die in the United States, yes, we tend to die, on average, a year, 2 years, maybe 3 years earlier than they do. But if you remove from the data on both sides all the people who are killed instantly in accidents and murders, take those out, because you can't blame the healthcare system because someone dies instantly in a car wreck or a bullet through the head. Take those people out, and we have the longest lifespan on Earth. So we have a problem. We have a problem with people getting killed, but it's not a problem that has to do with the healthcare system, unless you want to say extremely indirectly. And so the first thing when you start thinking about these is, let's clear away the stuff that ain't so. So what does determine how long we live? The biggest chunk of it up here, 38%, is individual behavior. Do you smoke? Do you drink? Do you expose yourself to killer diseases? Do you use drugs? Do you engage in dangerous sports? Do you drive fast? All of these things. That right there determines, and this isn't just lifespan, it's how healthy you are sitting in this room too. The biggest chunk of it is, what have you decided to do with your life? The next biggest chunk on here is your social circumstances. Are you married? Do you have children? Do you belong to a religious community? Are you educated? What have you done? All of these things. Do you have lots of friends, or do you have very few friends? These things, sometimes in ways we don't even understand, have a huge impact on how healthy you are and how long you live. Next is genetics and biology. Typically, these are things that you don't control. I can blame mom for whatever problems I got in that respect. Dad too. And now we're getting to a point, actually, where it becomes possible, it is already possible, to edit your genes. And if you have a lethal genetic illness, we are reaching the stage where there are methods of editing your genes just the way you would edit a document that you're typing out in Microsoft Word. That if your child has the genes that are going to kill him or her from Huntington's chorea at around age 39, it will be possible in the not too distant future to go into their body and edit it. But for most of history, it's been, these are the things that you're handed, that we can't do much about, and we're still quite limited in it. Now what you can do is you can learn about your genes and negotiate around them. If you have a gene that makes you susceptible to obesity or to alcoholism, it can tell you, well, knowing this might have to do something over here and change your behavior. And we are getting to the point of having really sophisticated ways of determining what your genes mean for the future of your life. Up here is 7%, which is your physical environment. Do you have clean water? Do you have, do you live in a dangerous area? Are there pollutants under the ground where you live? I don't know, do tornadoes sweep through where you live a lot? So these things. What it remains is about 11% of your health is determined by health care. Just 11%. That doesn't mean it's not important, but it means it's not the big explanation of what's right and what's wrong about you. It's an influence. It's not the biggest. So what this tells you is there are a lot of things you can pull from this diagram. What it can say is maybe, and just a maybe we're dumping too much money into healthcare and not enough into things that change the environment, things that change your behavior, things that change your social circumstances. I always have my students, so I teach this wonderful group of doctors and nurses and administrators over at VCU once a year. And I always have them read an article by a Nobel Prize winning economist who invented the field, basically, of economic history. And what he does is he takes an incredible amount of data, starting in the Middle Ages and going through today, and saying, why do we live so much longer and so much healthier today than we did 100, 200, 300 years ago? And he knocks out healthcare, and he knocks out even public health, like clean water. These are not the big determinants. And what he finally zeroes in on is the big determinant of how long you are all going to live is how well did you eat when you were in your mother's womb and outside of the mother's womb for about 4 or 5 years. If you were well nourished in those years, on average, you're going to have a much longer life than people who were malnourished. And actually, his message was an interesting one. He was speaking to a group of pension managers saying, we have the first cohort of Americans or of anybody in world history where almost nobody was denied nutrition in their early years, which means we do not have a single solitary idea how long today's people are going to live. And he said to these pension managers, you had better be prepared for these pensioners you are funding. They might live to 90, 100, 110, 120. It's been, I forget whether it was in that article, but it has been said, there's a geneticist at UCLA who says, in all likelihood, the first person in history to live to 150 years of age is already alive and living somewhere on Earth today. They're not 150 yet, but somebody out there, some child is likely to make it to 150, and we just don't know how prevalent that will be. So this diagram means we have to do some serious rethinking about the priorities. And let's see. Here's another Josh Billings thing. So when the Affordable Care Act was passed in 2010, the biggest single reason that was given was we have vast numbers of people going to the emergency room. The emergency room is the most expensive place to get care, and we're spending a fortune on that. So I just wrote an article, published it out there, you can find it. I'm going to pull his shoe off because I've got a cramping toe, which probably caused by genetics, but I have absolutely no idea, but it hurts. But anyway, so we wrote an article saying, and this I co-authored it with David Goldhill, who's the author of one of the best healthcare books out there on the market. He is not in the healthcare field. He is CEO of what was formerly known as the Game Show Network, TV network, and game producer. And David's argument has long been, and I just sort of amplified on it in the article, and we worked together, was that that the emergency room may in fact be the cheapest place. I don't know why I'm having that, but I'm going to give a little health care to myself. That will be part of my lecture too. Anyway, if you think about the emergency room, so you go to your doctor, what do? You've got the sniffles, you go into the doctor's office, you sit in a chair for a while. Eventually a nurse takes you into a little room and puts you there and takes your temperature and takes your blood pressure, and the doctor comes in, asks you a few questions, and then you go on your way. Is anything different about that in the emergency room? No. And in fact, in your doctor's office, you're sitting in a much nicer waiting room. probably sitting for a lot less time. You are when you're being checked in an emergency room with a couple of sheets around you instead of some beautiful walls. Magazines aren't as nice. And the doctor's office is only open 1/3 of the day, which means that for 2/3 of the day it's gone wasted. So those of you who know what fixed costs are, 1/3 as many people have to absorb the full extent of the fixed costs. So anyway, so in some ways, it may be the cheapest place to get care in the emergency room. So why do we pay so much? We pay so much because some accountant says it should cost a bunch, no more. And I said, okay, so back in around 1980, there was this famous case where the US government paid $2,228 for a monkey wrench. In today's money, that would be about $6,600. So you can get a wrench for, in today's terms, $6,600, or you can go to Walmart and get it for between $5 and $30. So that means a monkey wrench is either the cheapest tool in your tool shed, or it's the most expensive, just based on what some accountant writes a check for. And that's kind of the problem with emergency rooms. It's not that the care really consumes more resources, it probably consumes less. It's just we have built a kind of a crazy system where we're paying odd amounts for all sorts of things that doesn't make much sense. So this is one of these things, if you're trying to solve the healthcare costs by shifting people out of emergency rooms and into, nicely paneled doctor's offices, you may be going just the wrong way. Someone may write a smaller check, but ultimately you may be consuming more resources, making it more expensive. So what we're doing, and again, this is not a one-party problem, we're doing all sorts of odd things. So I came up with, in some of my recent writings, something I call the calendar test. So we're getting back to that 1922 calendar. Only this is the doctor's daily calendar of appointments. I said, so imagine, and by the way, that up there is the title of the article that I published on it. Just about all these things you can Google up, and I'll show you where to find any of these if you want to read more. Imagine a doctor works 10 hours a day, 5 hours of which the doctor is doing things that do not include seeing patients. Doctors have to do administration, they have to keep their records, they have to have staff meetings, they have to go for continuing medical education, they have to read journals, they have to do all sorts of things. They have to tend to their electronic health records, which the government has told them you've got to keep, which they don't like, and with good reason. And they're going to conferences. Probably have to play some golf. And the other 5 hours, they're seeing 20 patients at 15 minutes apiece. Now, somebody goes out on the street and hands out 4 gift coupons that say you are entitled to see this doctor today. So there are basically 4 ways the doctor can respond. First of all, the doctor can work longer hours. Say, fine, I'll just stay an extra hour or 2 hours. And these 4 may be sicker and older than their existing patients, so it may take longer. So the doctor might spend another hour or 2 a day seeing them. They may not like that. It certainly doesn't cut costs to do that. The second thing they can do is they can shorten the visits. So you can take 15-minute visits and say, instead of 20 of those, I'll have 24 12.5-minute visits. Well, already, when the doctor sees you for 15 minutes, most of that time is actually taken up by playing with a computer and filling out electronic health records and things. So what you're really talking about here is, of 7.5 minutes, you're going to cut out 1/3 of it, which means your doctor's going to have a lot less time to think about you and think about your problems. Third thing the doctor can do is to tell 4 of the existing patients, I'm sorry, I can't see you after all. I got 4 guys off the street. You're going to have to see me another time. Now imagine telling this to every single primary care doctor in the United States and say it's not just for today, it's for every day. And then let's extend it to specialists, to hospitals, and others. And here's where I'll just slightly touch on the political end of it, and I do this in Washington. What I've just explained is what the Affordable Care Act did. It said there's a whole bunch more people who now are entitled to care, but we're not going to produce a single new doctor, nurse, hospital bed, or anything else. We're going to jam more people into the same resources. And then I look to my friends on the Republican side of the aisle and say, and the thing that you're trying to pass now basically does the same thing. What we're doing is trying to shift deck chairs around the Titanic. You're trying to make big promises to more people without expanding the supply of what it takes to care for them. And to me, that's just shuffling chairs around. The fourth way is to actually change how we deliver care. How your doctor deals with you, how you deal with illness. And so the criterion that I have, the calendar test is, if you're telling me your big idea to fix healthcare, I'm going to ask you, does it make more space on the doctor's calendar without compromising anyone's care? If the doctor has to work longer, it fails. If the doctor has to shorten the appointments, it fails. If the doctor has to cut out some appointments, it fails. But if somehow you can see more people at a lower or at least the same cost, then by gum, it's passing my calendar test. And there are three ways you do that. You take some of the care that doctors were doing, some of the ways that a doctor was caring for you, and shift that care away from the doctor to someone who isn't a doctor, who's someone less expensive, maybe a nurse practitioner, maybe a therapist, all sorts of other professionals. Or secondly, and I'm going to show you a lot more on this, you shift some of what the doctor was doing to machines and let the machines take care of you. And there are some remarkable ways that's possible now. And the third is to take some of the care and shift it to you. Basically in the same way that banking found out that you didn't really want to stand in line to cash a check. You're much happier going to the machine, as I am. If you want to go see the teller and have a chat, that's fine. You can still do it. Most of us prefer to go to the bank and do a nice impersonal function and be done with it and get on the way. So 3 ways to shift. And now I think my own health care, which I took care of without a doctor, the problem has rectified itself. And I will put my shoe back on. And you have just seen medical care done by the patient. Anyway, there's Mom again, 1940. And here she is, very close to 75 years later. Mom held together pretty well, I got to tell you. If I can do as well as she did, I'll sign that contract today. She was, up until about 2 weeks before she died, she was as sharp and quick and quick-witted as she had been when I knew her in her 30s. Kind of a remarkable case. She was a handful, but she was a smart and alert handful. So I spoke here in 2015. I don't think I talked about it that day, but just a couple months before that, before she had a couple of bouts of illness that year that ultimately put her in and out of the hospital, one time being just before the lecture here that she was able to get out and come see me. But the most interesting and most critical and one I've written about a lot and talked about was Mom didn't always understand technology, but she sure wasn't afraid of it. And by the way, she talked to older people who were afraid of email or iPhones or iPads. She had no use for them. She just, she could be impatient with folks. At some point she said, I don't really like hanging around with old people because invariably the conversation turns into an organ recital. Said, this organ is failing and that organ hurts, whatever. And she said, last thing on earth I want to do is listen to an organ recital. So she liked her iPad. She loved it. She didn't always understand what to do with it. She would call me and say, the iPad was misbehaving, it was doing this, so I thought maybe Verizon would help. I said, Mom, Verizon doesn't have anything to do with your iPad. She said, well, I called them and they fixed it. I said, fine, whatever works, Mom. And she loved FaceTime. Does everyone know FaceTime? So I have read that iPads are extremely popular among the senior set, basically so they can talk to grandchildren, and that's how she used it. So one night she was talking to her grandson, who is an emergency physician, as is his father. And Ben was asking her how she's doing. Mom at the time was 92. And she said, I'm doing pretty good for a 92-year-old. She said, I only complain. She said, I've got a sore down here. And I have to tell you that she might have a problem if I was telling. Actually, she didn't. She let me write this in an article without complaining. But the week she was dying, and she was half in and half out of consciousness, the nurse came to turn her, and I don't know, her flap opened, and she said, stop that, we are modest people in our family, and explained to her. Well, anyway, so when she was talking to my nephew, she said, I've got this sore, and it's bothering me, it hurts, and it doesn't seem to be getting better. And I'm going to go check it out. I'm going to see the doctor. I'll make an appointment maybe next week. Anyway, he was just looking at her. How many here have actually used something like FaceTime to talk visually? Okay, so about half the room or more. Ben started looking at her as she talked. And he started observing the color of her face, her breath, the pace of her breath, and other little telltale signs that a doctor would recognize. And he got a little worried. And he said, Grandma, I hate to ask you this. Do you want to show me the sore? So Mom said, oh, what the hell? I'm 92. Who the hell cares? So she lowered it, took the camera, aimed it at the sore, and he said, let me talk to Dad a little bit, and I'll get back to you. So he called my brother. He said, Dad, I'm worried. He said, I think she might be going into septic shock. I think she might have a pressure wound there that has gotten grievously infected. So my brother gets on the horn, calls his daughter, says, go over and get her, take her to the hospital now. So they got her there, and indeed, she was mortally ill with the beginnings of a superbug infection. And you know, those things can kill you in a short time and not a pretty parting. Well, they pumped her full of every antibiotic you could. She had a hard time there, but she survived it. Lived another year and 2 months or so. Got to see a lot of things happen in her family that she would have missed otherwise. But the key was that he didn't have to be in the same room with her. Well, this is becoming, that's harking back to that 1924 drawing of the telemedicine of the future. And I talk to doctors who are terribly worried and unsure about it. So, well, you need to be in the same room. Need to touch the patient. And I've got a colleague, chief medical officer for a telemedicine company, I'll show you in a minute, who said he realized teaching hands-on examination at Stanford Medical School that about 90% of what he does in the office he could do just as well from a distance, maybe better. One thing is, I have some equipment now. I can, if I ever need to, I can plug a stethoscope into my iPad, let the doctor listen to my heart, my breathing, from at any hour of the day or night. There are all sorts of other capabilities it has. I will get, if I take a blood pressure reading at home, it's going to be a lot more accurate than whatever I do in the doctor's office. My wife is always going in, and her blood pressure's up here. Doctor says, just sit for 5 minutes. Now it's back down here nicely. There's just something about doctor's offices, it's not natural. So that's actually, since Mom was a modest person, I sort of fuzzed up the picture, but that's her a couple right after the FaceTime thing with her great-grandson and granddaughter and a good friend lying in her hospital bed recovering after a terribly hard week of barely surviving. But really, I think only surviving because it was caught early. She had waited to call her doctor like most of us do. I don't think she'd have been around. There's a company called Cerner. I've done a little writing for them, about them. They've developed a machine, a software package that you plug into the units here in a hospital room. And what it does is it uses the readings from the patient to try to figure out when a patient is getting sepsis, when a patient might be heading toward death because of an infection that no one has noticed and is too early to notice. And they claim that it has remarkable ability to predict this and for early intervention, and you can save a lot of lives with it. They've also noticed weird things, and this is typical of the technological revolution we're undergoing. It'll recognize the presence of microbes that are subtly changing your blood pressure and your temperature and your breathing patterns. It will also, accidentally, they discovered it also flags the onset of PTSD and thoughts of suicide. So this can be an early warning system not only for a bug that's living in you, but something that's going awry up here that's not biological in nature. It's something else. So remarkable things like that we're discovering, and we're only at the beginning of it. That's the article. Those are a couple of the articles. The top one is the one on, and I'll make this available to anyone who wants it. That's the article that I wrote on, among other things, Mom, and this is the one on this. That's Ian Tong. He's the Chief Medical Officer for Doctor on Demand. It's a company founded by, among other people, Dr. Phil McGraw. His son is chairman of the board of it. I've used it before. My doctor was away for 4 days. I didn't want to wait to deal with a sinus infection. Pulled out my iPad, clicked on it, bang, 24 hours a day. Within 90 seconds, a doctor sees you for $40. And 10 minutes after I called, there was a prescription waiting for me at CVS a couple blocks from my house. The company's in California, the doctor was in New York, I'm in Virginia. And yet I didn't have to wait. I was getting better by that afternoon. Ian, too, has a story. I've written about him. He had a similar story about a patient who called because her mother had seen their app on the Dr. Phil show. The daughter-in-law had had severe diarrhea, vomiting for about 4 days, was getting better, felt much better. But the mother-in-law, who had some sort of a nursing background, said, I don't like the way you look, and we're not going to wait. And she said, let's just go on the iPad and call these people and let a doctor look at you. And he told, and I wrote about what he was able to do from a distance. The mother took the blood pressure, did the heart rate. He watched her breathing. He said, let me put the camera right by your eyes. I want to look into your eyes. And he could see a discoloration. He said, hold your fingers like this to the camera. He could see the nails were white, meaning not much blood was getting in there. And he said, ma'am, it's the first time I've ever had to say this, but you need to get in a car and get to an emergency room immediately. You're, I believe, in mortal risk. And in fact, the woman was horribly dehydrated, was beginning to head into shock, and probably would have died during the night had he not told her. But the great thing was, she didn't have to go anywhere, didn't have to head to an ER, didn't have to make an appointment, didn't have to wait. And again, I've used this service. My son's used it. It doesn't replace your doctor. It supplements your doctor. So an iPad saved Mom. It saved Ian's patient as well. Lots of things are switching to this way. How do we clear the doctor's calendar? There's another colleague of mine, Dr. Jason Wang, who was a co-author of one of the best books ever written called The Innovator's Prescription, written about 15 years ago. Jason was a founder of a company called Lemonade, Lemonaid Health. And what they did was they identified a class of drugs, birth control pills, urinary tract, acid reflux, things where there's no compelling reason for you to have to go and sit in front of a doctor and have them measure how tall you are and whatever. And they built a system that allows them, a doctor there, to do checks to make sure you are who you say you are, to check your ID, to check your other prescriptions. And it walks you through, there's a click-off, a bunch of questions, and then a doctor reviews it. And Jason explained to me how time-consuming it is for your doctor to fill out a prescription. You go down to get a pill. How are you doing? How's your family doing? Really? So what's been the matter? Tell me about this, tell me about that, blah, 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 blah. Doctor has to type a bunch of things. After you leave, the doctor goes back and checks. Burns a lot of your doctor's time. He said they demonstrated in a clinical test, one doctor on their system can process safely and effectively 1,000 prescriptions per hour, because a lot of it is automated by computer and just tells the doctor, it flags, check on this patient, something's wrong with this ID, this patient's using this other drug, want to make sure that they're not getting conflicting drugs. And safely they can do 1,000 an hour. He said he suspects, it hadn't been proven, but he thinks that for the class of drugs they use, about a dozen doctors could handle the entire prescription load for the United States. This is how you start clearing your doctor's time and actually getting better care for less money. And it's not what we're talking about in the healthcare debate in Washington. This is a London taxi cab. Anyone ever been in them? London taxi drivers are amazing. They acquire something called the knowledge. The knowledge is a taxi driver. London has crazy medieval streets, extremely complicated. They don't have nice New York grid lines. And a London taxi driver, before he's allowed out on the streets, has to learn the entire layout of London in extreme detail. The test is highly complex. And furthermore, the knowledge they acquire in this couple of years of training is so significant you can actually see it in an MRI. There's a portion of the brain, the hippocampus, that begins to look different in an MRI scan after you've studied to be a London taxi driver. And then while you're working, that lump of knowledge is visible in an MRI. When you retire and stop, it shrinks and disappears. And so you physically can see the knowledge that a London taxi driver. Well, they're worried now about Uber. I got here today by Uber. I can give you all sorts of Uber stories about people who pop into a town, turn on their Uber app, and start driving people around. London's still kind of complex, but Uber's getting started there. And the stuff that you used to spend years putting into a taxi driver's brain and storing up and maintaining over the years through constant work is now on the border of being acquired like that just by turning on an app. A lot of medicine is going that way. Things that your doctor used to have to study for years and years and years to do, we can now put into a computer, and sometimes it's better. As much as we love our doctors, sometimes, as Jason Wang of Lemonade said to me, unlike your doctor, our app never forgets to ask an important question. It has its own shortcomings, but it doesn't forget things the way your doctor does. This doesn't mean we're going to replace doctors, but it means we'll use them differently. Now, I say Uber. This is a company, California company, just opened shop in Washington, D.C., in Northern Virginia. Heal is an Uber, literally an Uber of doctors, where you go on your app, you're sick at 7 p.m. and you're sitting in your apartment, you don't feel like getting up, going to an ER, hit the app, the doctor shows up at your door in 45 minutes, treats you at home, and goes on. And they believe, the company believes, it's extremely important so that people like my mother, rather than waiting, perhaps dangerously waiting to make an appointment, when you're sick, you bring the doctor right into your own place at that moment. And the doctor also can see how you live. As he said, how you live, that environment, may be as important as whatever bug that you happen to have. The doctor sees filthy dishes and 27 cats and whatever. Maybe this is a problem that we need to deal with. But, and now I'm going to do this. Let me check the time. I do want to make sure we have plenty of time for conversation, which we will. Now I'm going to talk about not an Uber sort of service, but the Uberization of medicine. It's a case, it's the second part of the title. I said an iPad saved Mom, an iPhone may save me one day. So I'll start with a question, and if I've talked to you about it today, you can't answer. So here's my iPhone, and it's got these two little squares on the back. Raise your hand if you know what it is. What do you think it is?
So, protect you from RF.
What's that?
It's to protect you from RF signals.
I think you're probably right. What's RF?
Radio frequency.
Oh, no. No, that's a good guess, but no. So, this is a device called an Alive Core, and I read about it. And about a year ago, in April, I was giving a lecture on it, and I was talking to 250 people who are executives who run health insurance plans. And I asked them the same question. I said, how many of you know what this is? And I didn't own one, I just had it on the screen. And I don't think there was one hand in the room. I said, this is an Alive Core. Let me explain what it does to you. I said, for someone with atrial fibrillation, a heart arrhythmia, I won't ask, but if anyone wants to volunteer that say, yeah, I've had something like that, or let's say someone close to you has had it, okay? I said, it can tell you whether you are going into atrial fibrillation or not. And I looked at the crowd and said, look, if you've got a patient who you're insuring who thinks, uh-oh, I'm having an episode of Afib, I better head down to the emergency room and get checked out. I said, when they get strapped up and they waste half the day being tested, and you find, no, you're not having any problem. Your insurance plan has just spent $3,000, $5,000 to tell this person, no, there's nothing wrong with you, go home. You've also wasted you've filled up a slot of a doctor's calendar. I said, secondly though, when one of your patients is having AFib, and ordinarily they would say, I'm okay, I'm not having a problem, and they are having a problem, and they have a stroke, you may be shelling out a couple $100,000 for care for this now badly wounded person who could have been helped had they gone to the ER in time to stop this. And I looked at these 250 insurance executives and said, how come none of you know about it? And how come you're not handing these things out like candy for every patient who comes in? An Alive Core costs $99. So I finished my talk, and the woman who had invited me was just talking to me afterwards and shook her head and said, I had a friend who was 38 years old. She had AFib. One day she was having an episode, didn't realize it, stroked out, keeled over, dead. She said, listening to your talk, I was wondering, would my friend be alive today if she had had one of those things sitting on her cell phone? So I said, it's an interesting question, might well have. I thanked her, I went to the airport, I flew home to Alexandria. Next morning, I opened my eyes at 6 a.m., and I feel my heart going like this, and I leaped out of bed and started running around in circles. I tried to take my pressure cuff to see what was wrong with me. It wouldn't even register. I went to my wife and said, we got to go to the hospital, something's wrong with me. I don't know what. So they strapped me up, and they said, yes, sir, you are having atrial fibrillation. Do you know what that is? I said, yeah, I kind of know what that is. So I told them I had just lectured on it the day before. Anyway, they knocked my rhythm back into shape in about an hour and a half, gave me every test you can imagine. Everything came out flying colors. Sometimes that's just the way it happens. There's no obvious reason it happened. It hadn't happened since. I'm on a medication to lessen the impact if it ever does happen, but whatever, so I'm fine. But I do have that thing on my phone. This was the emergency room where I went. Now, about 10 days later, they wanted to give me the one test that I hadn't had yet, which was a treadmill stress test. And they said, okay, the medications we just put you on, you're gonna have to stop it because the test won't work. The treadmill won't measure what we want if you're on a beta blocker. So I said, fine. So I went off, and their machine was broken when I went in, so I had to stay off of it, and I come in. So I was off for like 4 days. I'm sitting at home playing the piano, 6 or 7 o'clock at night, and all of a sudden I feel bang, 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 bang. And I'm going to my wife, Alana, I think it's happening again. So she hustles me off for the second trip to the emergency room. They strap me up. They say, nah, you're just running a little fast tonight, but that's normal. But there's nothing wrong. You're not having Afib. And 3 hours later, I went back home. And I thought, somebody just paid $3,000, $4,000, $5,000 so a doctor could say, nothing wrong with you. And I was, of course, thinking of the AliveCore, which I had ordered, but I didn't have yet. Anyway, back on the beta blockers, I went and gave a lecture in Western Pennsylvania. And honestly, I've traveled all over the country. I had no idea how empty Western Pennsylvania is. I was right about here on this road, which I think I got off of Google, but that's about where I was. And when this picture was taken, it was a busy night on that road. There were just no cars, no towns, no nothing. And by this time I had 2 devices. I had my AliveCore, I had my Fitbit. And I'm driving along. And I was, this is 6 weeks, 8 weeks into this thing. I'm not particularly nervy anymore. But immediately after it happened, I was kind of a little skittish, on edge. And I was listening to my heartbeat as I'm driving along. I'm not paying attention, except I felt it going like this. And I start touching my Fitbit, and it's going 60, 65, 70, 75, and I'm going, what am I going to do out here? I said, I'm not even sure I have a cell signal if I need 911. There's no cars here. There are no towns nearby. I started thinking, the nearest town back was Altoona, which was, again, 15 to 20 miles away. I said, maybe I ought to start thinking about heading back that way, which I didn't want to do because I was trying to get home, and I had another 4 hours to go. And it was getting pretty fast. It went over 100. And finally, I got a gas station. I pulled over, and I said, well, I've got this little baby now. So, let's see. So, I did this. Put 2 fingers on each one. I clicked record now. and you won't be able to see it, but it started doing it. What it takes is 30 seconds. Right now, my heartbeat is faster than usual up here, 73 beats per minute, because I'm walking around and pretty vigorous up here. If I'm sitting, it drops back. I know it now. What you see there is from my Fitbit. I can go back any day over the last 14 months and pull up something. This trip was June 3rd, 2016. The yellow on the right is, you see, and by the way, I have no abnormalities. It has measured me, it has analyzed me and said, my heartbeat is fine right now. So that's the actual thing from that night. That's where my heart rate for, I don't know why. I now know, I've been tracking it for 14 months now. I know it does that sometimes. Especially does it sometimes around 7 p.m. after I've eaten a good-sized meal. Just digestion, probably nothing more than that. But I know that now, and I don't worry about it. And this is my Alive core. And this, again, June 3rd, 2016, 7:57 p.m. This is my actual heartbeat. And if anyone has a medical background, it looks perfect. It's running a little bit fast. It says that I was running at 97 beats per minute, which is very fast for me. I'm usually, if I'm sitting in a car, it's usually 55 or 60 at most. So it was a little fast, whatever. But I did this. I said, oh, no abnormalities detected. I walked around a little bit, drank some water, which you're supposed to do. I took another measure and said, I'm fine. I got in the car, drove 4 hours home, and thought, next year, when they measure America's healthcare spending in 2016, it's going to be several $1,000s less because I bought this $99 toy to put on my cell phone. Now, some doctors get real irritated and frightened by this. Some because they're genuinely concerned, and some because it's lost business. It depends. Maybe it's both. And I had one doctor I was speaking to, and she was just almost spitting mad, saying, if you want to trust your life to your cell phone, that's fine, but we believe in hands-on, personal contact between doctor, whatever. And I was, yeah, well, I do too. I've had, and coming from Petersburg like Peggy, she'll understand, I've had a total of 5 doctors in my entire life at age 63. The only time I've ever changed was because I moved somewhere, and I had to change doctors. I love my doctors. I do trust them. I place a lot of faith in them. I know their limitations too. And in this case, as much as I love my current doctor, she was not going to hop in a helicopter and fly to Pennsylvania and check me out on that road. And this did give me good guidance. It's FDA approved. It's a solid, it's as accurate as the EKG that the doctor will give you. This is just one of many, many, many devices like this. Just a couple months ago, $10 million was awarded. There was a contest called the Tricorder X Prize, Qualcomm Tricorder X Prize. What it was a contest. Anyone could enter. You needed to build a device that would accurately diagnose 13 health conditions, 12 diseases, and in one case, the absence. Capture 5 real-time health vital signs, independent of a healthcare worker or facility, in a way that provides compelling consumer experience. So it has to accurately measure by 70% accuracy, which is about what your doctor has, anemia, atrial fibrillation, chronic obstructive pulmonary disease, diabetes, leukocytosis, pneumonia, otitis media, sleep apnea, urinary tract infection. And then they had to also choose 3 from cholesterol screen, foodborne illness, HIV screen, hypertension, hyperthyroidism, melanoma, mononucleosis, pertussis, shingles, strep. Must accurately measure blood pressure, heart rate, oxygen saturation, respiratory rate, temperature, and it must be in a device that weighs no more than 5 pounds. There's a little handheld device that can measure all those things with the accuracy of a doctor. Colleague who put together that determinants of health chart said he expects that before not too many years pass, computers will be able to do about 95% of what your doctor does, and with the quality of a Harvard medical team. 23andMe, a genetics test. Spit into a bag, mail it to the company, they come back. They would tell you your genetic conditions on 250 conditions. So that then you could say, well, you know, I got these problems, I think I'm going to change my behavior and my social circumstances and all this. The FDA shut them down. They said you can sell it for genealogy research, but nothing else. Recently, they've been allowed to return to the market for 10 or 12 different things. But we're getting to the point where you're going to be able to do an awful lot of this yourself. So is it safe? Well, yeah. I mean, if you go back to the 1970s, when they first developed home pregnancy tests, huge part of the medical community was dead set against it because they said, first of all, if women can check their own pregnancy at home, they're going to stop going to doctors, they're not going to do prenatal care, and you will have loads and loads of suicides when women find out that they have an unwanted pregnancy and will kill themselves. So we need to keep these things illegal. And of course now, virtually every pregnancy is first determined by a home pregnancy test, and it's had just the opposite effects. It's actually been wonderful for interrelationships with doctors and patients. So part of it is understanding that people are a lot smarter and more trustworthy than people assume. I'm working on some research now on how we can redo the idea of electronic health records, which right now are time-consuming, painful, and useless from a clinical standpoint. They're good for insurers and bureaucrats, the government, who want to have a database. They don't serve much purpose for patients or doctors. I can see a point where they become useful, where everything from my Fitbit to my AliveCore to my general practitioner to my specialist all feed into one big thing, and then you have different readers so that when I go to the emergency room, they can suck out just the data that they need and not look at all the extraneous stuff. And it's feasible out there. Doctors would like it. It would be useful for patients. And so I'm working with an obstetrician gynecologist who's working with me on how do you bring these things into being. This is just, I'll skip this quickly, probably shouldn't have even brought it, but this is what a search engine used to look like. This is what they look like now with Google. If we still looked like this as they did in 1993, they were difficult to use, cumbersome, kind of annoying, ugly to look at. Google made a fortune by making it simpler. Why doesn't it have all these check boxes? Because it knows which boxes you would check off before you do. It's been programmed to read your mind and think about what you want, and it does a great job of it. This is Watson. How many of you know Watson? IBM's computer that won Jeopardy. Interestingly, it's been used for medical purposes. In a case last year, a Japanese woman with leukemia was not responding to treatment. She went to multiple doctors, multiple hospitals, no response. She was gravely ill. They couldn't figure what was wrong with her. And so they called in Watson. They gave Watson her charts, her medical charts, a sample of her genes, did a genetic scan. And Watson went out and read 20 million articles on leukemia and came back with a diagnosis saying, no, you guys got it wrong. She doesn't have acute myeloid leukemia. She has secondary leukemia caused by myelodysplastic syndromes, which I don't have the faintest idea what any of it means. The process of reading her charts, reading her genes, reading 20 million articles took 10 minutes. It would have taken teams of doctors weeks or months to do the same. And they immediately changed her medications. She immediately improved and went home. I have no idea how she's doing now, but it's remarkable. And this is going to become commonplace. You love your doctor. I love my doctor. There's certain things that a machine does better than a doctor. And we're going to be discovering those big time. And not every doctor likes that thought. But it's just something, this is again, how do you clear? You could have cleared several doctors a couple of months of their time on this case by switching to this computer rather than asking human beings to try to do the same analysis. These are some books that I highly recommend. Jason Wong of Lemonade was the co-author of this one. Eric Topol is probably the most interesting writer in America. He's a cardiologist. He's the one whose book, this book, The Patient Will See You Now, told about Alive Core. I will just put in a plug. Eric and I have a paper coming out this week at Mercatus. You'll be able to download it. I think it's a pretty interesting one. We look at paternalism in medicine starting in ancient Egypt and coming up to the present time when that's receding and we're moving more toward patients taking care of themselves, as his book title suggests. Let's see. I mentioned David Goldhill, the CEO of Game Show Network. That's his wonderful, wonderful book, How American Healthcare Killed My Father, How We Can Fix It. His father was, I believe, a doctor who died entirely unnecessarily of a septic infection in a hospital in New York City. And David, as an MBA CEO, said, how can this happen in the best city in the world for medicine, in a great hospital, with medical people who cared about him? How did a totally unnecessary death happen? And he wrote it from the vantage point of someone who does business. And this is a book on how machines are taking over human brain function. This is by a colleague of mine at Mercatus who argues that we need to allow innovators more freedom to develop. This is My Fortress and Frontier, and this, again, will come out this week, The Anatomy and Atrophy of Medical Paternalism. And that is that. With that, I'm done. So let me bring this up just because I kind of like the light when this is up. So what kind of questions we got?
Okay. I am a 32-year-old caregiver
Mhm.
to an older person and my mother-in-law. And one of the things that you touched on was telemedicine. But one thing you didn't quite go there, so I'm going to make the leap, is psych meds. When you go to see a psychologist or a psychiatrist, they refuse to do telemeds. Video conferencing. And here's why. And they say they can't keep it secure. So if I can give you a problem, that's one. And how do we bridge that gap? Because, it's not that they need to go in and touch them. We don't need that. They just need to be able to talk to the person, whether it's a social worker. So how can we bridge that gap? Or do you know of, because they won't use Skype, Google Chat, they won't use any of it.
Yeah.
So is that a possibility?
Oh, it's not only a possibility, it's out there already.
But they won't use it because they say the associations say they're not secure enough. That's what I'm being told.
Right. I'll get you next. But
Other countries do use Skype. I know that for a fact.
What?
That family that are clinical psychologists in South America doing therapy with somebody in Spain through Skype.
I
Okay.
would say these are big name doctors. I'm talking Hopkins and
Right.
PCU.
So let me say, part of it is we have an antiquated system of laws that penalizes you for doing things that weren't possible in the 20th century. And there's no doubt HIPAA is a problem. It had good motives. It's got some good features to it, but it inhibits doctors from doing a lot of things they ought to be doing. Liability laws are in are going to need some change. But let me talk to you about some of the psychological applications that are out there. So I've written about, or at least I've dealt with one called recoveryrecord.com. It was an interesting young woman in California. It's an app that's devoted to people with eating disorders. So what she has is developed an app, said just about every therapy for eating disorders involves the patient has a big stack of logs that they walk around, carry under their arm, and when they're sitting in a restaurant, they're writing, I ate a hamburger and some fries and this. My mood was bad. I was sort of depressed. I'm this and that and the other. First of all, it's inconvenient to be carrying all these logbooks around. Secondly, if you're doing that, half the people in the restaurant know why you're doing it, and it's embarrassing. So a lot of them would fall off the therapy wagon doing it. So she took it and put it into the form of an app. So now all the patient has to carry is this, and to fill in the data, the patient has to do this, and no one has any idea what you're doing. Everybody else in the restaurant is doing this, so there's nothing embarrassing about it. Last time I conversed, she had 350,000 patients on it, 10,000 therapists. And so it does a number of things. First of all, it allowed her to build the world's largest database on eating disorders. Secondly, it's connected to the therapist too. So when one of these patients, the app, the artificial intelligence in it picks up when a patient is beginning to fail. And it sends a message to that patient's therapist saying, she's in trouble, you might want to give her a phone call. So I was talking to a friend of mine about this, and I had no idea that my friend had suffered a near lethal case of anorexia and bulimia. And so she was talking to me about this, and she said, it's fascinating. I have a question. She said, when I was suffering and I was in therapy, the best thing in the world that I could do, she said, I was super at lying. I'd lie to my therapist, I'd lie to my family. I persuaded my family that I was eating well, and I wasn't. She said I had anorexia, so I switched to bulimia so they could see me eating and say, see, I'm much better, much better. And it nearly killed me. She said, how does the app deal with lies? So I speculated. I said, well, I'll bet it can pick up patterns that suggest lying, but I'll ask. So I asked the CEO. And the answer was, yeah, it can, but it's not so necessary because people don't lie to the app very much. They might lie to the therapist. When they're waiting for their appointment at 2 o'clock on Thursday afternoon, they might bolster themselves and say, I'm not going to talk about this, whatever. But in the still small moments of life, in the middle of the night, when they're crying for help and they really are, I want to get better, so they're not going to do it. They're going to say, no, I need to, I'm putting down the truth, I'm whatever. And so they tend not to. Now, there are other instances where telepsychology is beginning to boom in some places. I don't know how much it is with the VA. The VA actually is, for all of its problems, is actually quite ahead in the game on telemedicine. You're dealing with, the last thing you want is when you've got some disabled veteran who's living out in the country somewhere to have to hop into town to deal with a problem. What you want to do is to be able to deal with it at the moment it happens, and any hour of the day or night. So I think there's a lot. Yes, there are impediments. First of all, there are a lot of doctors who just are old stick in the muds and don't want to switch into that world. But also there are legal problems with it. Yes.
I think I'm one of those old stick in the mud RNs. I practiced nursing for 35 years. I'm also the granddaughter of two psychiatrists. Now that I'm an elderly person, nurse who was forced into electronic records. I resisted it to the extreme because I felt like I was focusing on the equipment and not the patient. I also love my doctor. I know that she is not perfect, but I have a great relationship with her. And it just shows you how medicine has changed. Because when I was in nursing school way back in the around 1980, what was stressed over and over was continuity of care. It was so difficult on patients. If there was a new RN, LPN, nursing assistant, with every shift. So the head nurse tried to structure continuity, the same nurse. And RNs like me really did not like being pulled to the desk to take orders off and to do the computer. They wanted to do bedside nursing. So then we had a trend where more nurses were back at the bedside, which most people like. But I think we're losing something with this technology. Just like when I go to restaurants and see young couples, each with their own phone, at the dinner table, not speaking to each other. My own son and his wife included in that. And wonder what precedent this is setting for grandchildren. But I think elderly friends of mine who were terminally ill that I go to visit in nursing homes. And then when they're crying and in pain in the night and hitting the call bell, I mean, they're not going to hit a nap. And then who's going to come and sit with them? And where's the doctor that they do have a long-term relationship with?
Well, that's all good comments. Part of it, I'll have to say, I think, is addressing a time that no longer exists. So I think, yes, some people in this room might never touch the app. I think most will. I love to show a video that was made in the 1940s by the Bell telephone system, explaining how to use these newfangled dial rotary phones. And it's a 15-minute video, and it focuses on an old guy who's saying, I like the phones we used to have, and I'm not, why don't I, and so I'm confused. And at the end of it, he tries it and makes a call, and the big bright light comes over his face. So yeah, I mean, there's going to be an adjustment period. But I think, yes, everyone will. If my 93-year-old mother could use apps as she did adeptly, if not always perfectly, I think there will be a time in the very near future where we're all pretty comfortable with it. We're certainly a lot more comfortable. I mean, the whole computer revolution is 25 years old. 25 years ago, as I said here 2 years ago, I knew one person who had a cell phone. And I knew people who were swearing, I'll never have one of those things. Oh, what do I need that for? Whatever. And some in my own family. Not mom.
But it seems to me that they're going to be diagnosing objective things. But what about the subjective information that an RN or a doctor might absorb? Like, what is this patient's mood?
Right, I agree. But a lot of what we now consider subjective is simply because we never figured out how to make it objective. So, for instance, let me go back to driving around as a metaphor only. The London cab driver, it took 2 years to train them to do it, and then it took a lifetime of maintenance to keep their mind able to drive the streets of London, because you couldn't automate it. Now with the app, I could go over there. Well, I don't know how to drive on the left, then I'm not going to even try. But other than that, I not long ago, I used an Uber driver in Washington. Washington's a pretty nasty place to drive. The signs are not very good up there. It's easy to get lost. It's confusing, a lot of big, ugly circles, you name it. So this kid was driving me around in Uber. I always like to talk to them. And I said, where do you live? He said, Chicago. I said, Chicago? I said, what are you doing driving here? And he said, I'm visiting my parents, and they're off for the day, and I was sitting around their apartment. I was bored, so I just said, I'll hop in the car and turn on the app. And I'm driving around Washington picking up people, and he drove as if he was someone who had lived there his whole life. Now, similarly, there are all sorts of things. I will never say that this is going to replace doctors. I like to say, there are an awful lot of things that either are rote mechanical actions that are wasting your time, that a machine could do better, or the patient could do better, or there are things that we're going to discover, like Watson, looking through 20 million papers and doing a diagnosis in 10 minutes. Now, maybe some of what you're talking about does need the one-on-one thing. But what it's going to do is clear a lot of time out of those people's calendars so they can focus on those things we haven't figured out how to mechanize yet. Now again, how much are we going to figure out how to mechanize? This is a question I frequently ask to medical groups and innovator groups. And what I usually get is 90–95%, if not more, of what doctors and nurses do today are going to be able to be done in the very near future by a machine that's going to do those analyses, which means, one, we're going to be able to use those doctors and nurses more effectively for the things we can't automate. And two, hopefully, we'll be able to do with a lot fewer doctors and nurses. Well, that sounds strange to say because we've been in a world where these things haven't been possible. Whenever I have my VCU students in, I'll have some anesthesiologist or cardiologist or someone who's highly paid say, Dr. Graboyes, 2 questions. So first of all, how can we get healthcare costs in this country down? 2, what can I do to protect my bottom line? I said, excuse me, I said, you do know when we talk about costs, that's you. So it may be that for the whole mass of this room, of doctors and nurses, you can't do both of those things. If we really want to get healthcare costs down, it means we're going to have to spend less on you guys, by and large, or your hospitals or whatever. There are these thought exercises I like to toss out. So what if we could come up with a magic pill, everybody takes one, and they stay perfectly healthy for the year, and we don't need you? Would that be a good thing? Well, no, it put a lot of doctors out of work. I said, well, a century and a half ago, 80% or more, 85% of Americans spent all day, every day, tilling the soil and growing food. Somehow we figured out how to do it with about 1% of the population doing that stuff. Is that a bad thing? Does 84% of the American population consist of farmers sitting around doing this, waiting for the day that they can slog around the cow pasture again? No. Right now, medicine has been an extremely labor-intensive and human capital-intensive field, where an awful lot had to be done by a doctor, thinking and training and spending. If we can actually replace some of those functions, taking the doctor who's wasting time writing prescriptions and stick it in an app that can be used 24 hours a day, safely and effectively, that's a good thing. Will it displace some workers? Well, I wrote an article not long ago in which I was talking about an old question that I've always loved to ask, which is, okay, I'll ask you. So 50 years ago, I'll put it in sexist terms because it was 50 years ago. So your daughter was a student at West Hampton College 50 years ago. Who did you want your daughter to marry? What did you want your daughter to marry? A doctor. Why? Because it was good income. Doctor, once got that degree, would have a nice income. Not the richest, wouldn't be making as much as an NBA center, but would have a good income, a steady income, an assured income, unless the doctor really screwed up. Now, if you were a parent in around 1795 in England, who'd you want your daughter to marry? Guesses?
Landowner.
Yeah, well, that's going to be kind of rare. That's like saying, yeah, I want my daughter to marry an NBA center. It's a nice thing if it happens, but it's not likely.
The Lord of the Manor.
Yeah, well, again, that's the owner of the NBA franchise, so that's not going to happen either. A weaver. Why a weaver? Because a weaver did a vitally important task. It was hard to get into weaving. You didn't just decide, I'm going to be a weaver. You applied to the guild. You would get an apprenticeship. You'd be an apprentice for 7 years. If at the end you were lucky enough to have done well enough to pass the examinations and get into the guild, then you could practice, and for the rest of your life, you'd be pretty well assured of a very nice income, a really good income. And unlike a doctor, probably no one was going to die if you screwed up at your job. You know, you'd mess up a bolt of cloth. And then the reason this worked is because you couldn't automate weaving. What happens around 1800? The Jacquard process. The Jacquard process. They invent a mechanical loom. That suddenly all that knowledge that used to be contained in the weaver's brain is a machine. And the weaver suddenly, their income dies away. Now, we still have weavers. We still have people in the textile industry. Some people make a lot of money in the textile industry, but they're not doing it this way anymore, unless you happen to be one of the very few specialty weavers who does handcrafted cloth for people who like that sort of thing. And I'm sure that in medicine you'll have people doing the handcrafted medicine too, both because of certain tasks require it and others because some people will like that. But every time we go through one of these technologies, we discover, oh, you know what? We can automate that stuff pretty well. And it takes a while to get used to the idea. And then we do. We automated farming. And suddenly we went from 85% of the American public engaged in farming down to somewhere 1 to 3%, depending how you count it. And we have more food and better food than we've ever had in the history of any country in the world. You were part of the first population in human history where starvation just doesn't exist. And that's a remarkable change, and it's also changing around the rest of the world. The last 25 years, for all the doomsaying, has seen more people rising out of abject poverty than at any point in human history. The same things are happening in medicine. And yes, it's hard to imagine it, it's hard to adjust to it, but we'll get there. And I'm quite confident.
Who is using Watson in the medical community, and to what extent are doctors using technology in their diagnosis?
Yeah, I can't say how much. Right now, Watson is something of a beginning experimental basis. Watson's pretty expensive. I don't imagine the time that was required on Watson to settle that leukemia issue in Japan was inexpensive. But you have to think, too, 17 years ago when we first cracked the human genetic code, it cost in excess of $1 billion to analyze one person's DNA. We're now under $1,000. These things have a remarkable change in the cost. And I think my favorite story about Watson, I'll just have to throw in, is that part of Watson's brilliance and charm is that when Watson's not working on a leukemia patient, Watson is out there reading the web, surfing just like you do. And so they had Watson asking questions at some patients' bedsides. And all of a sudden, Watson started using some of the foulest, filthiest language you can. Because Watson had gone into the urbandictionary.com and had picked up every nasty slang expression. And they had to tell Watson, how about stay away from urbandictionary.com? Yes?
A question came up earlier, and I'd like to know more about how we as users, say, future users of technology, how we will secure our transmission of information, how the other side will secure it, and is there investigation or exploration of how it can be tampered with, knowing that federal government, FBI, all kinds of intelligence agencies are hacked every day.
Right. Yeah, no, it's certainly a problem, but it's kind of like people who worry about, well, do I want to put my credit card number into some website? Say, well, You give your credit card number to that kid with all the piercings and whatever, you know, that you've never met before. You know, it's privacy and security are problems, period. In any venue, in any technique we have. Part of the explanation, and it's not a pleasant one, is just saddle up, because the privacy that you used to know is just not there. It's gone. And the world right now has a big challenge is how do you deal with it? And I showed you a book, Permissionless Innovation, by my colleague. And Adam's work really focused on the idea that the default setting should be allow a technology unless you have a solid reason not to, as opposed to the opposite, which is called the precautionary principle, which says don't allow it until you feel real sure about it. And as Adam says, if you spend most of your time trying to protect against hypothetical worst case scenarios, you will assure that the best case scenarios never happen. There are, if in 1990, Congress did a remarkable thing in the early 90s. Prior to that, the internet was a tightly controlled entity developed by the Defense Department, connecting a few high-level universities. And it had strict rules. No commercial products are to be advertised or discussed on the internet. That would be an ethical breach. No personal correspondence, no this, no that, whatever. Around 1990-91, Congress, a bipartisan coalition, was all set to tighten up the regulation of the internet. And somehow the technology community and others lobbied and persuaded, so you ended up, shockingly, with a bipartisan coalition that said, no, let's let up on it. Let's ease up, let's let the internet go. We understand there will be severe problems involving it, but instead of trying to stave them all off in advance, let's deal with them as they happen. So we're dealing with real problems, not hypotheticals. And I always like to point out, especially when I'm talking to Republican groups, that in fact, one of the major movers and shakers behind this was Al Gore. So he actually, for all the ha-ha laughter about that, he actually did have a significant role in unleashing the internet. So what could someone who was a naysayer have said in 1990? Look, well, if we allow cell phones and this internet thing out there, well, it'll conceivably be possible that people could use cell phones to coordinate airline attacks on skyscrapers. And they might be able to build bombs and detonate them from a distance using a cell phone. And they might be able to go into your personal financial records and steal from you. They might be able to destroy your reputation in a heartbeat. They might be able to wreck your life. They may be able to do that, this, and that, and the other. And they would have been 100% absolutely perfectly correct. But is there anyone who would say, therefore, I wish we could go back to 1990 and have landlines and typewriters, and and 12 channels of TV? I doubt it. We've made compromises. We have lost some privacy and some security. All in all, I think it's worth it. A good part of why 1 billion people have been lifted out of poverty in the last 25 years is because we have the internet. It's because people in remote fishing villages in India and Africa, rather than hoping that they take their fish to a market that wants them, they can actually log on and see, where can I get a good price for my fish? Where can I take it? And therefore, you've got people who a generation ago would have been starving, and now they're eating well. Their incomes are rising rapidly, more rapidly than any group like that in human history. And yet we've given up some security and some privacy. I think it's a fair bargain. You know, maybe we'll come to regret it. There are, but I doubt it. I just, I used to travel sub-Saharan Africa, as Peggy said. The difficulty of communicating was so it was just astonishing. I could talk to my wife once a week for a couple of minutes, if that. And I'll give you a little example. So Cadillac came out with an ad a couple of years ago called Dare Greatly. And it showed 5 innovators, including one of the Steve Jobs' partner at Apple, and a film director, and whatever. These were all people who came out of nowhere to build great things that no one would have believed they could do. And one of them was a hairdresser in Nairobi, Kenya, who rose up to become the internet provider for all of East Africa. She was just a sharp lady who figured out a need and figured out ways to get it and get financing, and now she's a venture capitalist and entrepreneur, traveling the world, financing big high-tech projects. So I saw the ad. I thought it was a great ad. I went on Twitter and I said, this ad is great. You should watch it. Here it is. And I also put the addresses of the 5 innovators in it, the Twitter handles. Next thing I know, I see this woman in Nairobi has clicked like. She liked my, my tweet. I quickly followed her. She quickly followed me. And then I began a conversation. This was, by the way, at 5 o'clock in the morning on a Sunday morning. My wife was asleep next to me in the bed, and I was sitting in the dark with this glowing screen. And I had a half-hour conversation with this woman, and I said, it's astonishing when I used to travel in your country 35 years ago, I couldn't get a phone call out to my wife. And here you and I are, and if we wanted a video conference, we could do that. And we don't think twice about it. This is a remarkable change. The world has just absolutely changed. And I dare say that if you went back 25 years and tried to explain this to your friends or to yourself, you wouldn't believe a word of it. My father loved technology. He died in 1998. He got to see the beginning of this revolution. He was just really excited. I think every day, how, boy, would he have loved this stuff. He'd have been on there every day. But no one 25 years ago could have believed it. I've got Apple Music. It doesn't matter what album that I've ever heard or what musician, I can go on right now and listen to that music as if I had bought every album that's ever been produced in the history of the world, and I pay $10 a month for the service. It's astonishing. So,
Question. I believe in technology with healthcare. I'm wondering what's going to drive it. Is it going to be a combination of things? Is it going to be consumers? Is it going to be producers of this technology? Healthcare providers wanting to provide higher quality care? Hospitals trying to reduce readmissions? Insurance companies trying to cut costs? What do you think will drive it forward?
yeah, I think again, if you had asked me 25 years ago what's going to drive the computer revolution, I certainly couldn't have predicted that a couple of guys in a dormitory at Harvard were going to launch something called Facebook and become billionaires, multi-billionaires overnight. They sensed a need which no one else seemed to sense, or let's say there were others who sensed the need for Facebook, whatever, but others didn't succeed in the way they did. So I think it sort of starts in a dual way with people who have a need and someone who notices that the need's there and thinks of a clever way to deal with it. And I think it's very difficult to predict in advance how it's going to happen. It's one reason I tend to be very skeptical of the government driving innovation. A lot of people think, for research in medicine, for innovation, the government has to dump money in it. Well, I spoke at a conference in Chicago and at one of the universities there, and it was a nationwide conference of people studying the process of innovation. And to be honest, it was a very left-wing group, and they were very, very strong advocates of the government driving innovation. And I'd given a similar talk to this, actually more similar to the talk I gave here 2 years ago. And I talked about a couple of strange cases of innovation. A puppet maker in Washington State who invented a prosthetic hand that rather than costing $5,000 cost about $50. And I talked about the actress Hedy Lamarr, who was the world's most beautiful woman and also happened to invent a device to stop the Nazis from jamming radio-controlled torpedoes, and her invention eventually became Wi-Fi. And I also talked about my doctor in Petersburg, Virginia, who performed the world's first stem cell transplants for cancer patients at Petersburg General Hospital, where I was born. You, Peggy, were you born there? I said, look, I'm not that worried about the government cutting its funding, because think of it this way. Think who the government hires to dispense that money. They hire people like me. Someone's got a PhD and sits in an office. I said, who am I? I'm kind of an academic. I've never started a company. I've never met a payroll. I've never invented anything. I've never patented anything. I've never marketed anything. I've never done anything like that. I write about it, and I'm a fascinated outsider, but I don't have any, I've never done those things, and yet I'm the one who's supposed to look at a stack of proposals and decide why this guy is going to be the one. And I said, I've just told you about the puppet maker developing the hand and the actress developing the radio-controlled torpedo, and the small-town doctor who performed this. I said, if I were at the National Science Foundation, I would never give $1 to any of those three people. I would give it to a guy who won the Nobel Prize 25 years ago and hasn't done anything useful since. And when he failed once again to do anything useful, I could say, on my resume, I gave money to a Nobel Prize winner, and that would be a good thing. I said, so if you really want to get this out of the box, strange innovation that explodes the world, you're not going to get it by some guy like me sitting in a bureau in Washington dispensing the money. You're going to get it through a strange interaction of crazy people in garages developing things for consumers. Tim Cook, who took over from Steve Jobs at Apple, said, and I'll get the quote a little wrong, but basically, my job is to give you something that you never knew you wanted and to make you wonder how you could possibly live without it. So it's that interaction. And a good part of my writing, Fortress and Frontier, is we've put in a lot of laws and regulations that really stifle that. We have a health insurance system that starts with Medicare that says, Medicare is going to pay for this, it isn't going to pay for that. Medicare, to my knowledge, is not going to pay for this thing. And why it doesn't, I don't know, because somebody in Washington with a PhD or a master's or something said, we'll pay for this, but we won't pay for that. And yet this thing, I told you, had the capacity to save thousands of dollars every time I worry that maybe I'm having Afib. And I always wonder, why aren't they paying for those things? So we have a problem in the insurance system, and it's not going to get better by centralizing the insurance system more. We have lots of laws at the state level that prevent nurse practitioners from doing certain things that are reserved for doctors, but which nurse practitioners can do perfectly fine. We have some states which severely limit telemedicine. We have states which regulate all sorts of things and stop us from doing things that are safe and effective and less expensive. And so part of the answer to your question is we got to stop sitting on innovation and preventing it from happening. And I think that's the biggest issue out there.
I have a two-pronged question. One, when you were deserting the road, when you were having your attack, and you checked your paperwork, where would, if you had needed advice, would have been a non-issue, more or less,
Yeah.
It had to be done by hand, by the old-fashioned way.
Right, and it goes both ways. Yes, like I said, it will allow doctors to do what they really need to do. On the other hand, it'll help overrule them when they don't. So there was a great case a couple of years ago where up in, I think it was Vancouver, there was a woman who had a brain tumor in a terribly dangerous place. And the doctor said, the only thing we can do is a very, very risky operation where we essentially cut open her skull, lift her brain out of her head, cut this thing. She's very likely to die during surgery. She will almost certainly be blind if she survives and have all these other terrible effects, but that's the best we can do. Well, she was lucky. Her husband happened to be a technology guy. He worked in computer animation, like for the movies. And he said, I don't believe this, and I'm not going to trust that the doctors know what they're doing on this. So he said, I'd like a copy of the data from her MRI. I want to play with it. So they gave him the data. And he took it to his video sequencing. And then, so the prosthetics I talked about are produced by a process called 3D printing. And so it's like a Xerox machine, only it does it in 3 dimensions. It layer by layer by layer builds it up. So what he did was he took the MRI and had it print a copy of his wife's head, brain and all, and the tumor and all. And then he was not a medical person, was playing with it and looking at the way and studying the structure of her bones. And he went to the doctor and said, how come you can't just like take her eye out, go in that way, and get it there? And the doctors were kind of, well, maybe we can. And that's just what they did. And she was fine. So to some extent, you need the capacity to overrule doctors, as smart and wise as they are. And one of the problems is that, say, around 1960, if you were a doctor, you knew a vast percentage of total medical knowledge. Today, your doctor knows this much in a room full of knowledge because there's just so much information out there. Like I said, Watson had to pour through 20 million papers to figure out the woman's leukemia. Well, your doctor isn't going to do that and can't do that. And so there's simply a lot of situations where you're going to have to automate it, and we will have much better care as a result. We're already getting there. And you know, part of it's a natural struggle between doctors looking at it and saying, well, we didn't used to do it that way, and newer ones saying, well, that's the way we're going to do it in the future. There's, I forget who said it. There's an old saying that says, scientific progress proceeds one funeral at a time, which means the old scientists are going to have to die out before the new ones say, you know, they were great guys, but they didn't know everything. So no, we had, yes?
Are there any research projects going on now that deal with drug usage? For example, there's so many different types of antibiotics and how to relate them to a particular illness or disease. Are there
Oh,
something
lots.
going on there?
There's lots and lots and lots. There's a catchphrase out there called personalized medicine. Now, the way we've done medicine since ancient times is we look at this whole room full of people and we develop a pill that sort of works on average. You know, why is this pill 50 milligrams? Because, I don't know, we looked at a room like this and we tried 25 and it didn't do enough, and 75 killed a bunch of you, so we'll stop somewhere at 50. But the fact is, everyone in this room has different needs. 25 milligrams might be good for you, 75 good for you, 50 good for me. We're getting to the point where we can actually measure those things. And at least the people who do this tell me that we are getting to the point where, right now when they test a new drug, they get thousands of people and they give them half of them the pill and they give half of them a sugar pill and see what happens. It's getting to the point, it will before too long, so I'm told. I'm not a biochemist, so I don't want to swear by it. It's secondhand knowledge to me, that someone will be able to read your genes and say, we don't even have to do a test. We can tell this medicine in this quantity will interact with her genes in this way, so we can sort of custom build a pill for you and you only. The first 3D printed pharmaceutical was approved about 2 years ago by the FDA. It's a particular, I forget what the illness was or what the medicine was, but it's one where you can't use the average size because it will radically affect different people in different ways. So what you had to do was custom build a pill for every person. And so what you do is you have this machine that sits on a desk, and you feed in the software and say, for you, it's going to print it like this at that size, and for you, it's going to do this size and whatever. And so everyone gets an absolutely customized pill. I mean, using this technology just, I like to say that in the last year with my little problem, I have entered that period where I've got one of those pill counter things. So I've got to go through it and say, well, I have achieved it. I now get senior citizen rate on Amtrak, and I've got a 14-day pill planner thing. It's entirely feasible at this point to use a 3D printer to take all of my medications and put them into one pill, so I don't actually have to think about doing all those and to time release them. We're not doing that yet for a variety of reasons, but we'll get there too. So instead of that thing, pop one pill a day or a week or whatever, and it'll time release them all in different ways. So there's a huge amount of genomic medicine studies out there on how it works, and we're really reaching the point where medicine will become extremely personalized. Because right now, again, since ancient Greece, if not longer, we've been playing to the averages, and there is no such thing as an average person. You're always giving too much or too little or the wrong thing because you're trying to deal with a whole population. So there's lots going on in that. What else? Yes.
Do you have bradycardia? Do you have bradycardia?
I know the expression. I don't know what it is. So.
Low resting heart rate.
Hmm?
A low resting heart rate.
Oh, well, I now have a wonderful heart rate. Since I'm on beta blockers, I have, it's 45 at night. It's about 55 during the day, 50 to 55. The odd thing, after I started on the medications, I went to my doctor. She's asking, how are you doing, whatever, and I said, I have kind of a weird question. She said, what's that? I said, do these medications make you mellow? Suddenly I feel like Perry Como. And she laughed and said, yeah, they do. So I didn't know, but I hadn't read this, but she told me, and I've read about it since, that beta blockers are not only used for Afib, they're also used by people who are afraid of public speaking, which I am not, never have been, for people who are performance musicians who have stage fright, because it makes you mellow. And because it's sort of, normally people with stage fright, their heart starts doing this, and the adrenaline pumps, and they whatever. So yes, bradycardia is the opposite of tachycardia. I don't have that, but I've got a very nice resting heartbeat, and people always get amazed when they see it on my Fitbit or whatever, and then I explained that it's a little bit artificial. If I stop taking my beta blocker, it goes up about 15, 20 beats a minute, but it's still pretty good.
You say that these things are gonna come to fruition soon, or, in the works. It took the doctors and the government, to get the doctors to start putting stuff on databases,
Mhm.
and everybody having some kind of way of getting at their medical information.
It took the government to do that because what they said is, doctor, we want you to spend an enormous amount of time to put data on that is utterly and absolutely useless to you and to your patient.
And what's it stop them from doing that same sort of thing?
Well, that's kind of what I do for a living, which is write about stop that. Government, stop doing that. Let the doctors do what's useful. Just like there are lots of technologies, if you try to cram it down someone's throat in a particular way that it isn't clear to them why you're doing it, they're not going to want to do it. The electronic health records we have now are lousy. They are there to serve insurers, and they're there to serve the government. They're not there to serve the patients or doctors. And until you get to things, so here's a little example I love to throw. So at George Washington University Medical Center, back in the, I guess, early 90s. So my brother and my nephew are emergency doctors, and I didn't quite realize what a remarkably new field that is. So I read a book on the day Ronald Reagan was shot, which was 1981. And they took him to GW Medical Center to the emergency room. Emergency room at that time was a room with some curtains in it. And the doctors who were staffing it were just guys who were doctors elsewhere in the hospital, and they sort of rotated in and say, you'll be on emergency duty today. There was no concerted field of emergency medicine. And there was no systematic measurement of what worked and what didn't in an emergency room. That's very new. So in the 1990s, some doctor over there decided he wanted to build a database of what do doctors do in emergency rooms, what works, what doesn't work. And so he knew what he needed to do was to get his fellow doctors to enter lots and lots of data. And he knew the last thing on earth anybody in there wanted to do was to help him with this project and to type away at a computer and enter data. So he was kind of a cheeky character. So what he did was he put the computer in the middle of the emergency room floor and put a sign on it telling the other doctors not to touch it. The other doctors said, well, hell with him. I'm going to type it. And they would sit down and type, and he had built sort of lures in that were sort of interesting. So, Google knows everything about you, and they sell that information, and they could build an incredible psychological profile on you. You want to do some telepsychology, ask Google what's wrong with your head. They'll know better than your doctor will know. And how do they get that information? Because they gave you a useful product to sit down and do searches. And all this data on you is just sort of a spillover effect. So how are you going to get doctors to do it? You're not going to get it because some guy like me in a bureau in Washington says, doctor, you need to sit down and waste your time doing this. You're going to have to build in a reason that makes a doctor want to sit down and put in this information. And you're going to have to do things so that as a consumer, I want access to my medical information. And if I want to put my Fitbit on it or my AliveCore or my blood pressure readings at my doctor, I want to be able to use it. But until I can go back and forth and play with it, and my doctor finds it useful to do that, it isn't going to work. And the government hitting you with a stick and telling you need to do it for your own good isn't going to be the way it happens. It never happens that way with technologies. Apple, I remember I think it was Henrico. Early on, Apple gave away computers. Lots of them, their early computers. And schools said, I don't know, what do we do with these things? And he said, it isn't going to cost you anything, so I'll give them to you. So they got the computers, and people started, and they were just toys, basically. They didn't do a lot of useful things. But they were free, so the school said, sure, we'll take them, why not? And every student gets one and starts playing with it, and one student goes, you know, I found something kind of interesting to do. And then the other students and teachers say, well, that is kind of interesting. Let's do more of that. And so sort of accidentally, not because anyone said, you need to do this, but because they made it useful for people to discover things to do. That's how you got to the computer revolution we got to. So that's how we get to it. And how does it play out again? If you look at all the things on my iPhone, all the apps, whatever, 20 years ago, 25 years ago, I wouldn't believe that they ever would have been there. It's been said if you took someone from 25, 30 years ago, 50, or at least let's say 50 years ago, and brought them to our time, and put them on this side of a wall and you on that side of a wall, and let them ask you questions, they would assume that evolution had really taken off and that we were an entirely different species now. So, because, you could ask the person, how do you say, please pass me the spaghetti in Nepalese? And the person could say it. And the person would go, how do you do that? And, what's the capital of the Indian state of Uttar Pradesh? And and we can answer anything now. Things that we didn't used to need to answer, I feel compelled to answer now. I'm watching a movie with my wife, and, okay, there's a character actor standing in the back of the room in some scene. Who is that? I've seen him before. And then she starts yelling at me, saying, put the phone down. You don't need to know who that was. Why, yes, I do. But again, it's because I wanted to do those things, not because anyone told me I had to do that. And so that's the way a lot of it happens. That's the way every great technology has happened, because they made it in such a way that people wanted to use it. What else? I know I think we're a little into overtime, but is there anything else anyone has?
I'll just say there are refreshments out here. Maybe everybody would just like to join you in the conference and we can talk some more if you'd like.
Would love to, and this has been a fantastic audience. And as my mother would say, I don't like everybody.